Well, welcome everybody. We're off-site from the new GUCAS studio today. I'm here with my colleague Dr. Renu, who's the co-chair of the
ANZUP 2023 conference. That's right, Declan. We're at the Melbourne Exhibition and Convention Centre, or Convention Exhibition Centre, whatever you want to call it. It's ANZUP 2023, and Ben Tran and I are co-convening this year, and it's been a great day so far, and we've got a lot of highlights to bring you, don't we?
It's a great meeting, the ANZUP meeting. So for those of you who don't know, ANZUP is our cooperative oncology trials group here in Australia and New Zealand. They've run lots of successful trials over the years, really multidisciplinary group led by Ian Davis and colleagues, and they run this very nice annual scientific meeting with a bunch of international guests, and it's one of my most favourite meetings, I must say.
Yeah, well, very multidisciplinary meeting, and the theme of this year's conference, Declan, is bouncing back. So, take what meaning you want from it. It was Ben Tran's choice, and I'm sure it, implies lots of balls of all types, basketballs, testicles, testicular cancer, bouncing back after COVID. It's so nice to be back to face-to-face meetings, and I think we're all happy to be here.
So we're going to try and track down a few people to have a chat with. Some of your friends are here, some guests, international guests, and also they put us on the program. GUCAS got on the program this year.
There's a GUCAS battle. We have to get the old boxing gloves out. So Declan and I are up against each other in a debate about your favourite topic.
One of our favourite topics, yep. So we've been asked to do a debate on the role of adjuvant immunotherapy in renal cell cancer. Some of you might remember, we'll put a link at the end of the podcast. We had a fantastic debate with Alex Wyatt and Tony Shueri, Ben Tran last year about the Keynote 564 study. So we've been asked to reprise it. So, except we're arguing against each other. Our cosy host relationship is being challenged.
That's right. We gave Keynote 564 quite a grilling last time. So we're going to have to be on opposite ends this time.
So who's arguing which way again? I can't
remember. We better check that program.
It's I'm inevitably arguing against adjuvant IO, and Dr. Eep is going to argue for, and there'll be an audience vote. Who's going to win?
Oh, I'll have to see.
I'm going to win.
I don't know. It could go either way. Remember, there's a lot of medical oncologists in the audience here.
Anyway, stay tuned. That's coming up later in the program. But let's go for a wander and see who we can find.
Yeah, there's lots of international great guests and great ones, and I reckon I can see a couple standing over there. So let's go towards them.
Let's do that.
All right, Declan. So I've got one of our international guests at ANZUP 2023. This is Dr. Alex Wyatt. He's from the University of British Columbia, Vancouver Prostate Centre. Alex, welcome to ANZUP. Welcome to Australia.
Thank you, Renu. It's a pleasure to be here.
And you've done some wonderful talks here, and your research is fascinating, especially around ctDNA, circulating DNA. Tell us about some of the work that you're doing and some of the challenges with using ctDNA.
Yeah, thanks for the question. So, we work a lot with liquid biopsy, particularly in prostate and bladder cancer. And I think there's really two classes of kind of assay. One is about, can you detect any ctDNA in a person that you think might have cancer, whether that's in a neoadjuvant, adjuvant setting, and what does that tell you about their disease and their prognosis? And the other is, of course, when you have ctDNA present or somebody's got metastatic cancer, can you study the ctDNA, find things in it that can tell you about the biology or the vulnerability to different therapies? And a BRCA2 mutation would be one of the most obvious things there.
Yeah, wow, fascinating. And do you see a future where we can stop doing tumour biopsies to determine their, suitability for, say, PARP inhibitor treatment?
Yeah, well, certainly I think the liquid biopsy is a tool to get around repeat biopsy, probably. Certainly in a patient that has metastatic disease. It's probably something that can help us get around the fact that archival tissue is not always representative of late-stage disease, right? You have disease evolution, sampling bias. The cancer can change over time. So a liquid biopsy perhaps can be a better snapshot of your metastatic disease than an archival prostate biopsy tissue.
Of your full systemic disease burden. That's absolutely true.
Yeah.
And tell us about some of the other work that you've got going on in the Wyatt lab. What are your
so-
other main focus of research?
Yeah, so we're actually really trying to understand how to integrate liquid biopsy together with tissue profiling as well,
Yeah.
because we recognize not all patients have high ctDNA
Yeah.
levels, right? They're not all suitable for a liquid biopsy to determine actionable alteration status. So we have some projects where we're kind of combining tissue with liquid biopsy, and some where we're trying to understand how do you use different regions of the primary site to properly understand someone's metastatic disease. And I think one of the major focuses of our group these days is also understanding resistance mechanisms
Yeah.
to new therapies
Absolutely.
like lutetium PSMA.
Yeah.
So one of the reasons I'm here in Australia is because I collaborate so much with ANZUP
Yeah.
to help characterize some of the patient samples from their portfolio of trials.
Yeah.
And I'm really excited to find out what are the acquired mechanisms of resistance
Yeah.
to lutetium PSMA.
Yeah.
I don't think anyone knows for sure yet.
It's such a heterogeneous disease,
Yeah.
disease and population. So
Yeah.
this work is so important. And you've got a couple of interesting talks coming up. We look forward to that. And tell us about your time in Australia. What have you enjoyed so far? What are you hoping to do after the conference is over?
So I actually was, as a child, lived in New Zealand and
right.
came across to Australia a few times, but I never got to see Melbourne. So
Yeah.
it's been really amazing to see the city. The coffee is incredible. I didn't realise that before coming.
Yeah.
And I think what I want to do on my last day before I fly home is go for a run along the beach as far as I can.
Yeah. And you've already been to a footy match.
Yep, that's right. Yeah,
Another
that was an
tick.
experience. Yeah.
And you're from Canada, but your accent is very British.
Yeah.
So you've sort of been all over the place. New Zealand, where else?
Yeah, so that's right. I was born in London, and my PhD was actually in the University of Oxford.
Okay.
And I've ended up in Vancouver, Canada, via New Zealand, I suppose, as well. So yeah.
Brilliant. Well, you're a good friend of Australia and a good friend of ANZUP. Thank you so much for your time today and enjoy the rest of the conference.
Thanks, Renu.
All right, Declan. So I'm here with Laureen Buffart, one of our international guests from the Netherlands. Laureen, you're a human movement scientist. I think that is such a cool term. You're an epidemiologist by trade, and you've done a lot of work on the importance of exercise and exercise research in prostate cancer care. What are your top, maybe 3 messages for our viewers?
Well, the big message is that exercise has a lot of beneficial effects. Side effects from ADT. They're really, you lose your muscle mass, you lose fitness, and that thereby the capability of doing your daily functional activities. And exercise has a huge influence on improving fitness, improving muscle strength, body composition, and thereby allows you to, keep doing the physical activities that you really like to do. So it has an impact on quality of life.
Yeah.
I do think exercise is really important, and we do need to tailor it to each individual to make sure, to really personalize that.
Absolutely.
Yeah.
And how important is it to set up like an exercise program when you've got a multidisciplinary team looking after cancer patients?
Yeah, I think the supervision in the exercise by, for example, an exercise physiologist is really important on teaching patients how to deal with the side effects and how they can perhaps adjust their exercise to the side effects that they have to deal with.
Yeah.
Because your body is different than it used to be before, and so that supervision is really needed. Yeah. So, Laureen, one of the highlights of your many talks at this conference was your ANZUP X talk for me. So, for those who don't know, ANZUP X is sort of a free-flowing, conceptual type of presentation, and it's sort of embracing that concept that delivery of a talk and passion about a topic is really as important as giving data and facts. And Laureen gave our first ANZUP X talk for the conference, and it was about the power of passion in science. Yes, it was.
And it was interesting for me to know, because you're a keen, avid runner yourself, but that's not what got you into doing exercise physiology and biology.
No, I really like doing exercise myself, but when I really think about what inspired me to do my job is actually to help other people.
Yeah.
And so many people are affected by cancer, and I hope to contribute with my research that actually helping them to deal with the treatments and to actually maintain their quality of life in this really difficult period.
Yeah, and you also talked about the importance of keeping up the passion for what you do and the love for what you do. Isn't that right?
Yes, indeed, yeah.
And when you sort of find that you're losing that, maybe that's the time to take a step back and reevaluate.
Yeah, indeed, and also, if you're doing too much on the things that you really need to finish rather than what you want to do, and those are the first signs that you need to reset your priorities, what I really want to focus on. So that's one of the things that I remember. If I lose my passion, it's usually I need to reset my priorities.
Yeah, absolutely.
Yeah.
Well, Laureen, thank you so much for joining us. I mean, we've learned so much from you. You're amazing, and I hope you enjoy the rest of the conference.
Well, thank you. It's been a great conference, and really nice to meet all the people here. Thank you.
Okay, so I'm here with one of the superstars of the ANZUP conference so far. This is Professor Ananya Choudhury. Ananya, it's been wonderful to have you here. Have you enjoyed it so far?
It's been absolutely fantastic. First of all, I get to come to Australia, and not only
which you love to do.
I love to do. I love to come to Australia. It's my third visit, and each time I get something very special out of it.
Yeah.
And then I get to come to ANZUP for the first time and meet all sorts of old friends. I've got my ex-fellows here, and we've caught up and found out what each other are up to. Old friends from when I did my fellowship out in Canada, and then new friends like Renu here. It's fabulous, it really is.
And for our viewers, Ananya, so you're a clinical oncologist based at the Christie.
I am indeed.
Yeah, and you were kind of, your first talk yesterday was in the Challenges in Clinics session that I was chairing, in fact. And you were kind of thrown into the lion's den a little bit, and you talked about some of the myths and realities of bladder preservation in muscle-invasive bladder cancer. What are your top 3 messages?
So my top 3 messages are, first of all, radiotherapy and surgery are equivalent. There should be equipoise when we talk to our patients. And actually, I think all of us who do that find that patients have very clear ideas about what the priorities are for them and their treatment. And I have patients who choose to have surgery for very practical reasons, but I also have patients who, given the alternative, will choose not to have surgery, will choose to go down a bladder preservation route, knowing that if the radiotherapy is effective, surgery is there. And I think it's absolutely right that we give both these choices to our patients. So that's message number 1.
Very good, number 1.
Message number 2 is that if you're going to use radiotherapy, you should use a shorter schedule.
Okay.
So we published a paper comparing 6.5 weeks of radiotherapy with 4 weeks of radiotherapy, and we actually powered that study for equivalence. And to our surprise, and actually to my delight, we found that 4 weeks of radiotherapy was superior to 6.5 weeks of radiotherapy. And that's a win for everyone. Yeah. It's a win for the patient, less numbers of visits to hospital, less amount of treatment. It's a win for our departments, and it's cost effective. So again, I think that's no brainer. So if patients are going to have radiotherapy, I strongly believe they should have it in 4 weeks.
Course. Okay.
And then I guess my final take-home message is there's lots of data out there from the US, and actually we recently, colleagues did a study in the UK showing that bladder patients are undertreated and underrepresented. They often are the poor relatives within our urology services, because certainly in my practice, a lot of our time is spent seeing prostate cancer because there are so many men with prostate cancer that bladder unfortunately feels as if it's put to one side. So I think it's really important to have champions for bladder cancer. I think it's really important that we see these patients and offer them treatment, because if we don't, there's data out there to say that patients are undertreated. And if we do that, we're not actually doing either our patients or ourselves any real service.
And I think that's an important point, to have bladder cancer champions, because if you're going to set up a good bladder cancer program, that requires a very, it requires a very multidisciplinary effort,
Absolutely.
Doesn't it? And I think that, and it's important not just to have the doctors involved, but the support services around it to make sure these patients have a good oncological and functional outcome.
And I think ANZUP did that brilliantly this year, if I may say so, because there was a very clear voice from our nursing colleagues.
Yeah.
We have a specialist nurse over here called Rebecca Martin, who also comes from the UK.
She's brilliant, yeah.
And she has given a couple of really important talks about the patient experience from her perspective, but also from what we should be doing as a team to ensure that patients are supported. Because I'll be absolutely honest, my nursing colleagues are so much better at so many of the, I guess, supportive roles compared to us in the medical team.
Absolutely. And Ananya, your trip to Australia doesn't end with this conference. What are you planning to do? You're going to make me totally jealous, but what are you planning to do in the next few days?
Yeah, absolutely not. Part of the joy of coming to Australia is not just to do the networking and the academic stuff, but it's to see this country, right? I mean, how could you not? So having spent some time up in Queensland before ANZUP, tonight I'm flying up to Darwin. I'm going to go and see Kakadu National Park, and then after that flying to Alice Springs and driving via Kings Canyon to Uluru. So I'm hoping to see as much of Australia as I possibly can, just in case nobody invites me back.
Well, more of Australia than I would ever hope to see, I think, in my lifetime. It's been such a pleasure having you. Enjoy it, be safe, and we'll hopefully see you again soon.
Thank you so much.
Okay, so Declan, here I am with Andrea Apolo, one of our international guests here at ANZUP 2023. Welcome, Andrea. You're from the NCI. And it's just been such a thrill to have you here at the meeting. Have you enjoyed it so far?
Oh, it's been wonderful to be here. Australia is just so beautiful and everybody's so nice.
And you've given some amazing talks, but you know the most fascinating things you've said have been about the use of biomarkers in urothelial cancer. Maybe give us the top 3 messages.
So I think what's really important is that there's just a daunting amount of biomarkers right now being studied in urothelial carcinoma, and we still haven't found the biomarker to use for the different agents that we use, especially for checkpoint inhibitors. I reviewed PD-L1, I reviewed TMB, we reviewed a lot of the high-profile biomarkers, and I think one of the exciting things is how they're being incorporated right now into prospective clinical trials. There are clinical trials incorporating ctDNA as integrated biomarkers, and subtypes, molecular subtypes are being integrated. We know that FGFR3 is a target, and there are several trials targeting FGFR3. So I think that, as we build upon the biomarkers that are available, we can better select the patients that would do well with these biomarkers and minimize toxicity.
Yeah, absolutely. And what are some of the other areas of focus for your research?
Yeah, so I focus predominantly on immunotherapy, combinations, targeted therapy. We have a lot of exciting things going on right now. I have a trial through the Alliance. I have the Ambassador trial that we're awaiting the results for. That's an adjuvant trial of pembrolizumab in muscle-invasive bladder cancer. It's completed accrual. We have a lot of correlatives and biomarkers. I talked about it a little bit yesterday. We have the cabozantinib and nivolumab study for rare tumors called the ICONIC study, and that is enrolling and it's expanding in certain rare GU tumors such as squamous cell carcinoma of the bladder, small cell carcinoma of the bladder, also urethra cancers, which are really an understudied subset of urothelial carcinoma. We have a PARP inhibitor study with olaparib for selected group of patients, and I talked a little bit about this yesterday, but we have a specific trial looking at MMR deficiency and MSI high that is in development, where we screen patients with muscle-invasive bladder cancer for MSI high and MMR deficiency, and then select those patients for treatment with checkpoint inhibitor and potentially bladder preservation. So a lot of exciting things going on right now.
You're like a powerhouse of research. It's amazing. And we were very lucky, Andrea, because we got a little glimpse into your life, the path you've taken to become this incredible superstar that you are now. And you are such an inspiration. My question, I guess, and I'm putting you on the spot a bit here, is if you could, give one piece of advice to your 20-year-old self, what would that be?
I think be kind to yourself. We put a lot of pressure on ourselves, and we don't know what the future holds. And we're always wondering if what we're doing is right. I think trust yourself and enjoy it.
Yeah.
And sometimes we're just so busy trying to get to the end that we don't enjoy the path.
Yeah.
And I think enjoy it. And I think work-life balance is very important. Yeah. And a lot of times when we're young in our careers, we have young children, I think it can be very difficult to kind of balance them and enjoy your work, and then also enjoy being with your family, and you always feel guilty that you're spending too much time at work or that you're spending too much time with your family.
Yeah, it's a no-win situation.
Yeah, I think just enjoy it. I think I would tell myself to enjoy it a little bit more, and just kind of no matter what the future kind of brings, as long as you enjoy what you're doing and you're doing your best, that's all you can do. So
fantastic. There you are, folks. Dr. Andrea Apolo, an absolute superstar, and keep an eye out for more amazing work from her. All right, Declan, so I'm super excited. I'm here at ANZUP 2023 with none other than Darren Feldman from the Memorial Sloan Kettering Cancer Center in New York. Welcome, Darren, to Australia and to ANZUP.
Thank you so much. Great to be here. My first time in Australia, having a wonderful time.
Good. What have sort of been the highlights of the meeting so far for you?
Well, just get the chance to make new friends, see old friends, hear the latest updates in GU oncology, and I enjoyed the debates.
Yeah, and the debates. We'll get to the debates in a minute. Well, some of my highlights have been your talks, actually. This year the theme is bouncing back, which really indicates bouncing back after COVID. But a strong implication is testicular cancer, of course. And you gave a fabulous talk in the opening plenary yesterday that was focusing really on challenges in the clinic in GU oncology, and you took us through some of the myths and pitfalls in managing germ cell tumours. Maybe you could give us an overview of what are the, you went through a lot of cases, a lot of them your own actually, and it was really fascinating to see how these patients are managed. But maybe you could give us a couple of the pitfalls to avoid in managing germ cell tumours.
Yeah, absolutely. So I think it's really critical, since this disease hasn't had much new really developed in the last 20-25 years. We don't have a new drug. What we need to do is adhere to our guidelines and our standards and not veer off course. That's what we can do most to help our patients. So that's what I was trying to get across to the audience. So a couple of things, and they're not all earth-shattering. Some of them are just, kind of simplistic, but really important. So for one thing, I do see in my practice that sometimes others will use the pre-orchiectomy tumor markers to make decisions about treatment of patients.
Right.
And it's the post-orchiectomy markers that have prognostic implications, management implications, and what we use for staging.
Right.
And so it's really critical. People can get overtreated or undertreated if you use the pre-orchiectomy rather than the post-orchiectomy.
Well, that's really
markers.
important too.
Another pitfall is also going along with the tumor markers is that patients with poor risk germ cell tumors who start with a very high HCG, that HCG can often decline very slowly at the end of treatment.
Okay.
And it doesn't mean that the patient is actually resistant to chemotherapy. It just may take a little longer to declare itself. So it's better to monitor the HCG decline and wait for it to either rise or fall to normal or near normal before making a decision, and not just jump into salvage chemotherapy.
Right, yeah. Sometimes these simple, logical things are really profound to kind of keep reminding ourselves, not just in the everyday clinic, but also in the multidisciplinary setting when we're discussing these cases and the patients are not exactly in front of us. What about the role of, say, PET imaging in germ cell tumour? Because we do see this used quite often. We're fairly liberal in Australia with our use of PET imaging, especially for prostate cancer. But what is your take on the role of PET imaging in germ cell tumours?
I think the problem is if you're getting a test, you need to know how to interpret it. And that interpretation can be very disease specific. So in germ cell tumor, we have a problem called teratoma. And teratoma is a real problem that needs to be managed, but it's negative on PET scan. And so what gets people into trouble is that the sensitivity of PET scan is low because it does not account for teratoma. And what I've seen in practice is a patient will get chemotherapy, after chemotherapy for, let's say, non-seminoma, which is where we have to deal with teratoma, they have a PET scan for like a 3 centimeter residual mass. That 3 centimeter mass could have teratoma.
Yeah.
It's PET negative. They say, oh, no, nothing to worry about. We'll just watch that patient, instead of what the standard is to operate on that patient. It doesn't really matter. The PET scan's not going to help you because it's not going to differentiate between teratoma and necrosis.
So really take care in using these to kind of impact on your management decisions.
Right.
You gave a great debate today against Howard Gurney about the use of either observation or BEP chemotherapy in stage 1 non-seminomatous germ cell tumour. How do you manage these patients in your own practice? Sometimes you have to defend a point of view in a debate, but what's your practice like?
Well, I do think it's a pretty clear consensus, around the world that patients who who have stage 1 non-seminoma and do not have lymphovascular invasion or risk factors for metastatic disease, those patients really should be managed with surveillance. They have a less than 20% risk of relapse. There's no benefit in adjuvant treatment towards survival, and you'd be over-treating the vast majority of patients. And so it's very similar to stage 1 seminoma, where we also prefer to manage those patients with surveillance. The patients who have lymphovascular invasion is a more complex group. It's definitely very controversial. In my practice, I do discuss all 3 options with patients. I believe firmly that the doctor's job is not to make the decision for the patients, it's to educate them so they can make the best decision possible. And so I talk to them about the benefits of either surveillance, 1 cycle of BEP, or primary RP1D. Our institution tends to lean toward primary RP1D because we're most concerned about the long-term risks of chemotherapy, and that leads to the least number of patients undergoing chemotherapy in the end. So.
Well, I mean, one of the great things about this conference is we've gotten to know you a little bit personally as well, and we were at a dinner together recently, and Darren told us that he was in fact bitten by a monkey. It was hilarious. Has that made you a little bit nervous around the animals of Australia? Have you come across any that you've thought,
actually,
I don't want to repeat?
Maybe I didn't learn from my mistakes, but I've actually had the opportunity while here to pet some kangaroos.
Fantastic.
And did not get bitten.
There you go.
And I also fed some kangaroos, and
there you go.
I enjoyed it. So.
And live to tell the tale.
And live to tell the tale.
It's been wonderful having you here, Darren. I hope you enjoyed the rest of the meeting, and thank you so much for educating us on germ cell tumours.
Thank you so much. Pleasure to be here.
May not know that both Declan and Renu have a podcast called GU Cast. Very slick production. So normally they're co-chairing, but we've got them on the opposite side of the table, so gloves are off this morning. So I'll invite Declan up first.
Thank you. 2 against 1 already. Jeez. So thanks very much for this invitation and for allowing us, the cosy GU Cast co-hosts, to have a crack at each other. And this is, I think, deliberate sabotage from our rivals in the podcasting industry who are trying to, it's like breakfast TV show host wars when they're trying to, what's Kochi doing this week? What's Carl doing? This is the Carl and the whoever is on Channel 9 at the moment of the world of GU podcasting. So I've been giving this easy argument. Come on, adjuvant anything, to be honest with you. Us surgeons look extremely skeptically at. This is very well people we've just operated on, the majority of whom are cured, and you want to do what to them? Okay, you need to be very convincing to try and get people like us to send people like you, medical oncologists and GU medical industry, our lovely, mostly cured patients. So that's what I'm going to try and prosecute to you for the next few minutes. So my disclosures, what I've put up on this slide is myself and Renu's disclosures on GUcast, because this podcast has been running for over 3 years now, and it's got quite popular actually around the world. The vast majority of our audience are international. Although we have a video podcast, you'll see bits of that during to support my argument this morning. The vast majority of our audience are on Apple and Spotify. And as we became more ambitious and tried to create more content, and responding to suggestions from industry that they'd like to support the podcast, we created a partnership program. So our sort of inaugural partners that we're about to put up on the website are listed on the slide here. So we're very grateful to them, even you, MSD, for supporting the podcast. I think your contract is for a year, so it doesn't matter what I say, that's it. And thank you very much for supporting our ongoing educational program. So I've got 5 good reasons, just to keep it simple, 5 good reasons to say no to adjuvant immunotherapy for renal cancer. I'm going to summarize them here already, and I'm going to run through these over the next few minutes. And it's kind of obvious, like, nearly all the adjuvant trials are negative for their rather mediocre endpoints. They can't even reach the endpoint, which is not overall survival, for the vast majority of them. The one positive trial that we'll talk about doesn't even improve survival for these mostly cured patients. The side effects are unacceptable in the view of most of us surgeons, unless you show to us that these patients are going to live longer or live better. And how does immunotherapy help you live better when you're mostly cured from your oncology condition anyway? And the costs are nuts. We'll talk about that. And I will say to you that overall, for these adjuvant populations, we're much better off waiting for early salvage, because the salvage options that you have for us are so good. But I should reflect on the perilous state of the GU medical oncology industry before I launch into another attack on the GU medical oncology industry. This is from today's Oncology Daily, describing the industry in crisis as metastatic hormone-sensitive prostate cancer disappears forever out of the grasps of medical oncologists and back into the grasps of urologists. And I'll show you 2 slides to highlight that. The first one is bye-bye chemo in metastatic hormone-sensitive prostate cancer. This is the biggest crisis facing those of you with expensive school fees and a mortgage on your second house, who thought you were going to be in metastatic hormone-sensitive prostate cancer. Those of you who have expensive bicycles, who go on bicycle holidays, think, I've got metastatic hormone-sensitive prostate cancer. No, bye-bye. This is what I've been saying about it just this past week. History will record docetaxel as having had but a brief role in metastatic hormone-sensitive. You know that nice timelines they show Huggins up to where, and in the middle there'll be this bit from Chris Sweeney to about 5 years later, where docetaxel had a brief role. Now it's gone. It's gone. We have AR pathway inhibitors. Simple urologists like me and Renu know how to give these drugs, and we're not going to give chemo to these patients anymore. I've been punching home the message saying there is no evidence adding chemo will help you live longer. It'll certainly worsen your quality of life. The triplet crusaders, I'm now badging them, who are saying, no, because of this and blah, 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 blah. We should add, no, there's no evidence adding chemo to metastatic hormone-sensitive prostate cancer helps. And I keep just parroting the same line over and over and over again. So I understand, this is upsetting a few people around the world, but it's the reality check that urologists are back in charge of metastatic hormone-sensitive prostate cancer. Crisis number 1 for GU medical oncology. Crisis number 2, getting into our theme of immunotherapy, reflects the uselessness of trying to do immunotherapy in any type of prostate cancer. And when Neeraj, tweeted out a few months ago saying, breaking news, another huge setback to immunotherapy in metastatic CRPC, phase 3, massive trial, phase 2 improve outcomes, blah, blah, blah. Big sigh, totally unsurprising from me. Yet another failed trial of immuno-oncology in metastatic prostate. Can we please stop now? It's never going to work. The toxicity is not okay. The costs are ludicrous, hence the enthusiasm. Try a different cancer. And I'm building towards my argument for renal cell carcinoma, you'll see in some of these messages. But not everyone agrees with me. I mean, our esteemed chair of ANZUP immediately tweeted back saying, I'm not giving up on immunotherapy for prostate cancer just yet. There's every reason to think it should work. I'm the same. If I think hard enough, I'll lose weight or something. If I think about something, I just think about it. and something magical will happen. Let me tell you, it's not going to happen with immunotherapy and prostate cancer, right? So please stop doing it. Us urologists don't want to send you, we definitely don't want to send you patients for immunotherapy for prostate cancer. And I'll explain now why we're not going to send you patients for adjuvant renal cancer as well. So yeah, this is the podcast. Thank you for those of you who already are part of our audience who subscribe and send us nice ratings. This is from our new studio that we just did our first podcast from last week, which means we can do a lot more content now because we're set up in a kind of a permanent setting, which is great. And this is the podcast we did in August 2021, talking about Keynote 564, the positive trial that we'll talk about today. And I'm going to show you a few clips from this trial. So, yeah, you were there. You were on it. Ben Tran. Yep, you were there. What did I say? What did I say? Yeah, exactly. You'll soon find out, Ben. Right, let's go. 1, 2, 3, 4, 5. Almost all these trials are negative. So this is a caption competition. What do you think this is? Or does anyone know who this is? Bob Motzer. Bob Motzer, poor Bob. Does this one work? Bob Motzer. Bob is a GU medical oncologist. Does he not look like a GU medical oncologist who's reading out another negative adjuvant immunotherapy trial in renal cancer? That's what they look like. And there are hundreds of photos of like these on the internet of GU medical oncologists reading out negative adjuvant IO trials. This one is from, it was like a festival. They had a festival last year in Europe called ESMO. It was a festival of negative adjuvant trials. Okay, yeah, that's Bob when he had a positive trial before this. Look, same picture. So this is what it is, and this is from, I think, ESMO News. Like this is the industry trying to put a positive spin on 3 or 4, I can't remember how many negative trials. Yeah, they all just came up on stage and moped off again, and went on to Euromigos and tried to put a positive spin on it as usual. So that's the reality. The trials are almost all negative. Oh, there is one positive trial, the approved one, the one the FDA approved. The Americans love approvals. Approvals means they can bill for it. That's what it means. Is it approved? No, it's not approved. But can we bill? Can we blah blah blah? What about the positive trial, this famous trial? And some of the authors are in the audience. Howard, is he Howard? David Quinn, a bit early. David. No. So yeah, of course, eminent investigators. I'm not having a go at the investigators. This is a very well-designed study. I'm having a go at the endpoint though. So what are these patients? They're 75% are outside the US. That's very important when you consider the control arm. 86% are exactly the sort of patients Renu operates on, these intermediate to high-risk patients, as we see here. So they're not all super high risk. Lots of them are T2, grade 3, whatever, prostate cancer. And this is the famous endpoint that everyone's excited about, that the DFS is a bit different if you treat everybody with immunotherapy up front versus watch them. And what happens to the ones you watch, you might ask. But it's also very important to see on this control arm a few years later that the vast majority of patients in the control arm, of course, haven't recurred. That's because they had a nice operation and they're cured of their cancer. And they're living perfectly happy with no treatment whatsoever. And that's very, very important. And this is the overall survival. There's no difference in overall survival. What about if you follow it up a bit longer? This is the subsequent 30-month data. Yeah, the DFS holds up. Okay, breaking news. It didn't deteriorate more than we might have thought. But the OS, no difference, of course. So what does this mean? Let's listen to what we talked about on the podcast.
Do we have a sense in the control arm that when the patients do relapse, are they getting combination IOs, which we would consider to be standard of treatment? Because presuming that they're not actually getting or many.
And that's true. And if you look at this forest plot, you'll see that there's a difference between the ones who were in North America and the ones who weren't. And so the question is, what proportion of the control arm, buried in the supplement of the second publication, when they relapsed, the small proportion who relapsed, 25%, whatever, what proportion got what you would consider to be standard of care for metastatic prostate, what's the cancer again? Kidney cancer. Kidney cancer, what proportion? Well, less than half. Right, so as ever with a lot of industry-sponsored trials, it's rigged. The control arm is rigged. Let's make sure a lot of these patients are in Poland, where there's going to be no access to immunotherapy, even though in Poland, everyone on the adjuvant arm got their Pembro up front. But in Poland, when you relapsed, no, you didn't. You got a bit of old-fashioned TKI of some sort. So that's the problem, and that's what I'll prosecute in the final bit to say, come on, this is not fair. It's not fair. It's not the way any of you practice here, because when we send you a patient that has relapsed early, you're going to treat them with fabulous combination IO, which is what should be our comparator here. What about the side effects? I'm not going to go on about this. It's kind of the obvious thing. These are perfectly well patients, the majority of whom are cured, and of course they're going to have side effects. And side effects can be very serious for this population. This is the table S4 in the second publication, which goes on for 5 or 6 pages. I had to make a video about it. The table was so long, and my eye gets caught on the diabetes, of course. You take these well patients and turn them into diabetics or render them blind due to their retinitis, let alone all the common stuff, the colorectal stuff. So what do we think?
Toxicity and side effects.
What does Renu think about
this? That's a big concern for us urologists, Renu, isn't it? So,
yeah, exactly. And like you mentioned, Ben, it's the tolerability of these treatments and the fact of over-treatment and potentially avoiding these side effects in patients who may not need treatment until they become N1 or ever need treatment at all. How do we balance that?
Well, you're right. We can't balance it, Renu. I totally agree with you. But what about Tony Choudhury and Alex Choudhury? What do they think about this?
Tony, I want to play you a clip from your mate Tom Powell's when he discussed this with you on the Euromigos podcast recently. Big shout out to them. We love your podcast.
The look on Tony's face.
And Tony, we had a conversation with James Larkin. We had a podcast with him. And what James said that the melanoma field are learning is that there are some irreversible, potentially devastating side effects. And you need to see those once or twice, and it really focuses the mind. What worries you most about that statement?
Yeah, I think it's worth
and the costs. Let's talk about the costs. So this is a paper from our old friend Vinay Prasad. Going on. What does it cost? It costs, look at this. I thought it was $600,000 per event. It's $1.6 million you have to spend on Pembro to prevent one event in the adjuvant setting. It's nuts, right? So you're going to have to treat all these patients, and to save one event, $1.6 million. It's going to cost. So this is crazy.
And Alex,
we can't afford this.
It's not just linked to the drug, right? This is administered in a day therapy center. It's all that involved, all the extra blood tests we'll be doing. So there's quite a significant cost to society for giving this treatment. Yeah. It's for that reason, I think.
The gastroenterologist, the pulmonologist,
endocrinologist,
etc. And therefore, we shouldn't do that. We should do early salvage, which is exactly what our friend Alex Choudhury said to Tony.
Tony's fancy forest plots and his hazard ratios, won't fool the surgeons to send all of our patients to take pembrolizumab showers. I mean, it's just not what we're going to do. The data are preliminary, the risks are real, and the costs, Tony, are astronomical, right? So before we dive in, I would like.
And that's it. That's what I'm going to say. The costs are nuts, and the challenge the GU medical oncology industry, the clinicians, and the actual pharma industry have is convincing us urologists who love these patients, who've operated on them, the vast majority of them are cured, convince us that there's a benefit in treating all of these patients, exposing them to toxicity, no survival benefit, etc. It's not going to happen, and I'll hand over to my colleague Dr. Eapen to try and argue against me. Dr. Eapen.
I think it's working. Is that working? Yeah. I'm going to stand over here because the lectern is too tall and I don't want to compromise my position. All right. Well, my esteemed colleague Declan Murphy certainly has the gift of articulation, but I'm going to try and convince you to not be fooled by his cheery disposition and his Irish accent. He's completely wrong and he's completely missed the point. And I'm going to try and convince you that adjuvant immunotherapy for renal cell cancer is a great idea. So, I have a lot of respect for surgeons and urologists in particular, but Declan, you and I both know that surgeons... How do I do this? Play? Surgeons are just technicians. They're silly technicians. They come along, they cut out the kidney, they take out the tumour, and then they go away, they sit around and drink a little bit of scotch and smoke a couple of cigars, and they pat each other on their backs for a job well done. You've cured this patient. Meanwhile, 6 months later, this poor patient recurs, they develop metastatic disease, and then it's up to the medical oncologist to now try and save their lives. Or in the worst case scenario, nurse them towards an inevitable death. And this is just a situation that happens too often, and we have to put a stop to it. And we know at the end of the day that it's the medical oncologists that actually cure these patients. We know this. So why should we embrace adjuvant immunotherapy? Well, recurrence after surgery is common. Depending on the grade and stage of the disease that you're treating, recurrence after surgery is up to 80%. So we're not curing these patients. And the problem with recurrence is that it causes death. Recurrence is devastating. We do not want to be in clinic in a situation with a patient 3 months after their surgery looking at these CT scans. This is not a situation that I want to be in, and it's certainly not a situation that these patients want to be in. And renal cell cancer is a highly immunogenic tumour. There's plenty of T cells within the tumour microenvironment of renal cancer. T cells, for some reason, flock to RCC like, people flock to the MCG to see the footy. There's plenty of them there. And it is up to us to improve the quality and the function of these T cells using adjuvant immunotherapy drugs. And it's really important that we do this. Now, surgeons find the concept of immunology really confusing, so I'm going to keep this really simple, otherwise I might not be able to explain it myself. But, we know that tumours protect themselves by avoiding and evading the immune response. So what happens, and there's a really scientific explanation for this. So when there's a renal tumour, there's an antigen-presenting cell that takes, Declan's falling asleep, but bear with me. There's an antigen-presenting cell that will take a little sample of the tumour antigen, and it will present this sample on MHC class 2 to a T cell. The T cell will recognise it and will start to bind. But as soon as that happens, CTLA4 on the T cell will bind to CD80 and CD86, and it's like an off switch for the immune system. It causes immune tolerance. So anti-CTLA4 drugs prevent that interaction, and it allows the T cell to activate and proliferate and kill the tumour cell. In a similar way, tumour cells can also present themselves to T cells, and this is why MHC class 1. And we have evidence to show that renal cells will express both MHC class 1 and class 2. But when the tumour cells, when the T cells recognise MHC class 1, PD-1 will bind to PD-L1 on the tumour cell, and again, it's an off switch for the immune system. So anti-PD-1 drugs like pembrolizumab and nivolumab, and anti-PD-L1 drugs like atezolizumab will block that interaction and allow the T cell to proliferate and go off and kill the tumour cell. So there's a real explanation to how and why these drugs work. So what's the problem? Well, Declan mentioned this. There are many negative trials. And it's true. We've seen Checkmate 914, combination of Ipi-Nivo, not show a benefit. We've seen the Emotion trial not show a benefit. But we have one positive trial. Let's not let all that noise distract us from the fact that Keynote 564 is the almost holy grail of adjuvant immunotherapy in renal cell cancer. And we can scratch our heads and fry our brains thinking about why all these other trials were negative. And the truth is there are lots of reasons why these trials were negative. The trial designs were different, patient selection was different, the treatments were different. We know from Checkmate 914 that anti-CTLA4 drugs are toxic. Ipilimumab is not a very nice drug. And in this trial, so many patients discontinued the combination treatment that they didn't spend enough time getting the drug that would actually help them, which is nivolumab. And sure enough, we see in Keynote 564 and in the Emotion trial that there was a much lower rate of high-grade adverse events. What about the Emotion trial? Well, this uses a different drug. It's atezolizumab. It's a PD-L1 inhibitor. It has a different molecular target. The patient selections were different in these other trials. Tumour histology is different. Now, I know that Declan doesn't really like to read anything that's over about 280, 300 characters, but instead of reading all the tweets, if he'd actually bothered to read the manuscript of Keynote 564, he would realise that there, in fact, are a lot of strengths in this trial. It's a well-run, randomised phase 3 trial. The study population, sure, they're at a heterogeneous risk of relapse, but the majority of the patients on the trial did have T3 disease or higher. The trial was enriched for patients who had PD-L1 positive tumours, which is a perfect target for a PD-1 inhibitor like pembrolizumab. The percentage of patients who had a partial nephrectomy and local relapse were low, so that really highlights that the benefits of pembrolizumab were really due to a lower incidence of distant recurrence compared to placebo, and that's really important. And the trial didn't censor deaths without tumour progression, so they really limited the overestimation of the disease-free survival. So the disease-free survival benefit is real. Declan, you just have to trust it. And the importance for that is that it benefits our patients. You can see these curves here. Declan's already pointed it out. These, the survival curves remain, the DFS curves remain separate at the updated 30-month analysis. We don't have overall survival data yet, but that's not really their fault. I mean, only a third of the death events that were required to analyse it have occurred. That's a good thing. But we're seeing a trend towards better overall survival with pembrolizumab. And for now, that's pretty good. It's well tolerated. You know, the most common high-grade adverse event was hypertension. There was a bit of autoimmune thyroiditis. And I think Declan underestimates himself, because I truly believe that even Declan can manage these side effects. You know, if all else fails, you give some steroids, Declan, and if that fails, you know, you've got a great team of medical oncologists surrounding you to help you out with this. Importantly, there were no treatment-related deaths. That's important. I mean, that's more than I can say for a lot of surgical treatments. We just heard about the SWOG trial where significantly more patients died from an extended lymph node dissection compared to a standard lymph node dissection. This treatment doesn't kill anyone. And if we really needed another reason to be convinced, it's FDA approved. And we all know what that means. That's our green light to go forth and start prescribing pembrolizumab. But it's a very misunderstood trial. And, you know, Declan showed you a lot of video of you know, GUcast and the podcast really grilling Keynote 564. You know, and I think it's really unfair that these urologists, I mean, I recognize Declan, I have no idea who that is, and I'm pretty sure all the audio you heard of me was actually talking about prostate cancer, not renal cancer. But they teamed up with, you know, another prominent urologist, Alex Choudhury, and they used the typical surgical techniques of bullying and intimidation to completely overwhelm these two poor medical oncologists when all they were trying to do was defend a trial and a drug that truly helps their patients. And I think this is a real shame, and it really shouldn't happen. So in my mind, the question shouldn't be, is there a role for adjuvant immunotherapy? The question should be, what is the future after adjuvant immunotherapy? Do we use combination treatments? If patients progress on adjuvant immunotherapy, can we re-challenge with immunotherapy? What about tumour vaccines? We should be throwing a lot of money at answering these questions. So in the spirit of ANZUP, these are my top 5 reasons to use adjuvant immunotherapy for high-risk renal cell cancer. So coming in at number 5, we may be able to save patients from developing recurrence and metastatic disease. Why do you want to use multiple drugs to salvage these patients when you can use a single agent to prevent this from happening ever? We've seen a significant disease-free survival demonstrated in a well-run phase 3 randomized controlled trial, and we're seeing a trend towards better overall survival. The third top reason, pembrolizumab is well tolerated. There's minimal toxicity, there are no deaths. This is a great drug. Number 2, there's no better option for these patients. You know, and surgeons really need to get behind this, because if we really want our patients to be cured, we need to send them to a medical oncologist. Patients at the very least deserve to have an open discussion about this and make an informed decision. And my number 1 top 5 reason to use adjuvant immunotherapy for renal cell cancer, you ready? Don't throw anything at me. My number 1 reason for using adjuvant immunotherapy for high-risk renal cell cancer is the med-oncs have already lost metastatic hormone-sensitive prostate cancer to urologists. Please, let's at least give them adjuvant immunotherapy. Thank you.
Right. You might be wondering why on earth would be asking Henry Wu to adjudicate a debate on renal cell carcinoma when I just do prostate. Well, I guess that knowing that this was going to be such a toxic debate, it was probably appropriate that you have a urologist who has no skin in the game. But wait, people think that, well, hang on a second, Declan Murphy doesn't do much, with renal cell carcinoma these days, but don't be fooled by the fact that he is doing predominantly prostate cancer. This man knows a lot about renal cell carcinoma because we're interviewing people regularly on the GU cast. And also, you can see that, he actually went to a lot of trouble to prepare for this in that he left the dinner last night, particularly early, unlike Howard Gurney there, who still looks like he's been doing Saturday Night Fever for the last, 24 hours. But he went off to study, and plus he was, apart from the study there, he was counting on that Irish charm, and I have to hand it to him that he managed to produce a very good argument there, even though about 90% of it had nothing to do with kidney cancer. But that said, I think that people could say that we're all fair people, and that I think we could argue there's been a bit of a setup. And on that note, when you consider these comments, I'd like you to consider these comments when I ask you to ask for a vote on who you thought was the winner of this debate. Then I'll have a few comments about the vote. So, firstly, who feels that Declan Murphy provided the argument that supports no to adjuvant treatment? Can you raise your hands? Okay, and if you could have a vote for those who feel that Renu won this debate. Yes. Now, wait. We're all people of science here. We don't just simply go on, a bunch of data thrown at us. We need to know if this is statistically significant or not. And I've just done a quick run of the chi-squared analysis in my head, and I think that there's no statistical significance between the votes for Declan and Renu when we look at urologists versus medical oncologists in this audience.
But there's a trend towards it.
Yeah. Anyway, I'm sure you'll all agree that this is a fun debate in spite of the toxicity, and I'd like to get you to put your hands together for both Renu and Declan.
So there you have it, folks. Highlights from the ANZUP 2023 conference in Melbourne. We've had a fun few days of multidisciplinary collaboration and learning and making some good friends. We look forward now to next year's conference, which is going to be held in Queensland by our co-conveners, Matt Roberts and Aaron Hansen. I'm sure it's going to be a great meeting. Definitely some better weather, I think, for sure, but we'll see you then.